Okay. Hello, everyone, and thank you again for the possibility to talk today about a very important topic that emerged as a field of medicine in recent years, and that needs to be addressed when talking about mental health, but also when talking about andrology and sexuology. And as my colleague and Anne at the beginning talked specifically about gender dysphoria, in the second part of the series of talks, we're going to zoom out a little bit and talk about mental health in the LGBTIQ community in general. And to do so, we have to do obviously two things. We have to first understand what does LGBTIQ stand for and what is mental health, because you're all from a different field of medicine. I'm very happy to introduce what we do on a daily basis. And at the end, we will look at where we will have an overlap and why the LGBTIQ community affects all of us clinicians and why we have to work together on this issue. All right, this is going to be the agenda, as we've said. We first get an overview of LGBTIQ, of mental health, of the mental health conditions in the LGBTIQ community, and sexuality also in the LGBTIQ community. We'll then look at the reasons for mental health conditions in the LGBTIQ community, the concept of loneliness, which is very prevalent, what are protective and what are risk factors, and what we as clinicians and as a society can do to foster the well-being and the acceptance of the LGBTIQ community within. Okay, so let's start with LGBTIQ, an acronym that most, but maybe not all of you know what it stands for. And to all get on the same page, we will now start by addressing each of these words separately. L, that stands for lesbians, a group of homosexual women, so women that are attracted to other women, a prevalence of, here it comes. Yes, okay, 1 to 3%. The G stands for gay men, men that are attracted to other men. The B for bisexuals. And as we see, the prevalence of all of these groups are roughly in the same area. We then go to transgender, a group that we already addressed in the previous talk and in the discussion at the beginning. The intersexuals, that is a group of people that have characteristics that do not fit into the classical definition of either man or woman. So they have characteristics of both sexes at the same time. And a clinical example would be Klinefelter syndrome, where they have XX and Y chromosomes. And finally, the definition of Q, standing for the queer group, which is an umbrella term to encompass all of these before mentioned and other people. And when we add up the math of all of the prevalences, we end up to the number of 7%. So 7% of the population is estimated to be adhering to one of the groups that are enlisted here, making this minority actually a very, very big and important group in our society. 7% is a number that cannot be disregarded when we're talking about population health, when we talk about mental health, and when we talk about andrology and sexual medicine. Good. And what we also see is that this number is presented when directly asked by only 3.4% of respondents to a questionnaire, meaning that there is still a variety of reasons. One of them, obviously, stigma and fear of being exposed for people to openly talk about this issue. And while we have made a lot of progress over the last 20 years to address this topic, we still need to continue working on it. And I think this is why we all are here today, to furthermore deepen into this topic. Okay, that's so much about the overview and general impression of what the LGBTIQ community stands for. Now let's have a look at mental health, why my colleague and I are here today. It is a topic that encompasses the well-being on not only both, but in general on emotional, psychological, social, cognitive, and behavioral aspects of ourselves. So a very broad topic. That means we always have a lot to work, like you guys. It is also a topic that is highly prevalent. When we look here at the number, 970 million people worldwide are expected to face struggles that can be categorized as a mental disorder. That means that we are roughly 8 billion people. 1 in 8 people has some sort of mental disorder if it were to be categorized. Now, as most of you know, this then varies between cultural groups, between countries, but it gives an estimated overview of this condition. We also always want to show data on how big and important certain topics are. And what we can see here is that mental illnesses as of 2013, so 10 years back, was the 5th most prevalent condition affecting people worldwide. Now, if we would include dementia, which we do in Germany, into this category, it rises up to rank 3. If we continue to include self-harm into this category, we arrive at 11% of conditions, and even chronic pain syndrome to 13% of all conditions that are addressed in the global burden of disease to be connected to the mental health and mental well-being of patients. So that shows us the relevance of mental health, of mental well-being, and the patient population of LGBTIQ to be included in the taking care of our patients. Now, next, what we're going to do is combine these two. We've looked into the definition of the LGBTIQ. We have learned a little bit about mental health and why it's important. So far, so good. Now we want to see how the LGBTIQ community is affected by mental health disorders and what might be reasons why they develop psychiatric syndromes. Okay. And what we can see, or what we found in analyzing several meta-analyses, is that the LGBTIQ community has, in general, significantly higher risk for mental disorders than heterosexual individuals or comparative groups. It has an up to 5 times higher risk for mental disorders. It has up to 3 times the risk of suicide attempts. It has a higher level of prevalence of depression, anxiety, and drug misuse, as we have already seen in the slides of my colleague before. So there is a big amount of mental health conditions, of risk factors for the LGBTIQ community. They face struggles that already in general are rarely talked about. Mental health is not very often discussed, and they have an even higher risk for developing any of these syndromes that we categorize as mental health disorders. So it is urgent and it is necessary that we address, not only as psychiatrists and mental health workers, but also doctors of any category working with the LGBTIQ community to address these issues. Okay. I brought with me some slides here to show you the scientific basis for what we're saying, so that you can actually trust that we're not just giving out numbers, but these are based on studies that were conducted in different forms, and they all find the same results. You have a higher risk ratio for mental health conditions in the LGBTQ community compared to the non-LGBTIQ community. This applies to a list of mental health conditions. Here we see the case for individual substances that we discussed before. You see that the risk to develop, for instance, an alcohol dependency go up to 7 times more likely than in heterosexual control groups. Okay, that's so far to the, bless you, to the prevalence of mental health conditions. Now, something closer to your field, sexuality in the LGBTIQ community. And while there's a wide array, a wide list of stigma related to this topic, we shall have a look at scientific findings of questionnaires that were handed out to the LGBTI community. And what was found here is that there is a lot of problems of the LGBTI community facing their sexual behavior. That regards, for instance, the self-estimated quality of sexual behavior, like how satisfied are you with your sexual life. And here we see that the number is twice as high for people of the LGBTIQ community, indicating that they were not happy with their sexual life. Same trend for, whoops, there's a pointer. I come and do it with my hands. For sexual desire, we see that the feeling of sexual desire, as we heard already in Professor Giannini's talk also, is lower in the LGBTIQ community compared to heterosexual groups. So that amounts to 11.3% of the LGBTIQ community rarely or never feeling sexual desire, whereas in heterosexual control groups this was a lot lower. Same applied to the feeling of sexual of having their sexual needs fulfilled. Here, 18% of the LGBTIQ community indicated they did not have this feeling, whereas in heterosexual control groups, this was significantly lower. This number was significantly lower. Okay. And lastly on this slide, but very important, and also important for clinical implications when we talk to people of the LGBTIQ community, is to be aware that there is a significantly higher number of people of the LGBTIQ community indicating that they have realized or that they have experienced sexual trauma, whereas in 30% of heterosexual women indicated so, 36% of the LGBTIQ or the women of the LGBTIQ community indicated so. So taken together, sexuality in the LGBTIQ community is a topic that we need to address and that we need to address jointly and as andrologists, sexuology doctors and psychiatrists together, because we see that there's a lot of frustration of unmet feelings and of also sexual trauma experienced in this group. Okay. Now, we have the understanding of the LGBTIQ, we have the understanding of mental health, and we have combined the two. Now we're going to look at the causes for mental health disorders in these groups. And for that, we also rely on studies that were conducted, and taking these studies together, there was a common finding, and that common finding was that of a minority stress theory. The theory that being part of a minority group in the context of sexuality and gender identity leads to certain very specific stressors to these groups. And as we can see here, these are oftentimes associated with a variety of stigmas that these people face that we would not face or that we would not see in heterosexual control groups. That is, for instance, being socially excluded, being looked at differently, as Anne very powerful words described at the beginning. The fact that once you enter a room, you feel like some people look at you differently, judge you whatsoever. That leads to stigma coming from external parts, from the surrounding, but also a feeling of being isolated, what we call internalized stigma, where you think you are something different or problematic and you deserve to be excluded. So you have stigma from various directions affecting you in these cases. You also have microaggressions, you have physical attacks, you have social repercussions at work, at elections, at marriage equality, etc., etc. And this eventually leads, as we've said before, to a self-devaluation at the end, even the perceived feeling of being someone not part of the community, someone having a problem, someone being different. And that is, for psychiatrists, of course, something where we've always fear to go eventually. This is where you want your patients never to go, to a place where they themselves think that there's something wrong with them. This stands for the LGBTIQ community. And a very distinct group that we wanted to present also is the group of bisexuals. Yesterday we had with Professor Bach and Professor Giannini a little talk already about this, because there is this phenomenon that bisexuals as a group face within the LGBTIQ community an extra layer of isolation and stigma. And that is not only coming from heterosexual peer groups, but also from within the LGBTIQ community, like lesbians or gay men, considering bisexuals, for instance, as immoral, unstable, what do we have here, hypersexual, confused, disloyal. So even within the LGBTI community, there are stigmas that some groups express to others. And this is where we need to be sensitive, and we need to understand that each letter in this word, each letter in this word describes a very vulnerable and individual group that we need to address when dealing clinically or as a society with people of this community. Now, this so far for the causes of mental health conditions in this patient population. What we're going to do now is look at a suggested link of stressors, of causes for mental health conditions and the mental health conditions and disorders in the LGBTI community itself. So what could be a link between the minority stress theory and mental health conditions? And what we see here is that the crucial link that is oftentimes suggested is the feeling of loneliness, the feeling of not being part of a group. As we can all imagine, being not part of a group is already a big stressor for us. When, for instance, someone tells a good joke, you didn't hear the joke, everyone's laughing, but you cannot laugh with them. You are not part of the group, you're excluded, you don't feel well about that. Now, what happens in stigma, what happens in social isolation is this fact times 1,000, times 10,000. You're being socially excluded on a broad range of topics. And that is hypothesized to be the link between the minority stress theory and mental health conditions, and was even shown to be statistically significant, because we always work with statistics, statistically significantly associated not only with psychological distress in general, but at the end, eventually, even with suicidal behavior. So a fact that needs to be addressed. Okay. Looking at the data, we found then that the level of loneliness that people of the LGBTI community indicated was significantly higher than in heterosexual control groups. And not only that, the level of isolation was a lot worse in the LGBTIQ community compared to the heterosexual control groups. So this phenomenon of stigma and isolation and exclusion is something that is very prevalent and very powerful in a detrimental way when we look at the mental health conditions of this population group. Now, this for the general case. Now, something bad happened on top of that, and that was COVID, an illness that affected many of us clinicians, obviously, on a very daily basis, but also many people on an emotional, of a social level, where everyone needed to be separated from each other. Everyone needed to stay at home, could not leave. We all were, in a way, separated and isolated ourselves. And now what happened to the LGBTIQ community was the social isolation getting even worse. They could not gather in support groups. They could not go to schools, at universities, where oftentimes there is a sense of community, of sometimes mental health workforce that could help them be there to talk about issues, and that could avoid being stuck, for instance, at home, where they might face traditional family values, where they find stress but no relief. And this led to the fact that the LGBTIQ community was disproportionately affected by the COVID pandemic, and still struggles with symptoms that exacerbated during the COVID pandemic. Okay. Now that for the problematic part for the problems that people of the LGBTIQ community face. Now let's look at some positive data. And that is this slide. It actually contains quite some information taken together, because we see two things, or actually three, but we will focus on two. We see here in red the level of acceptance towards the LGBTIQ community. And then we see in the black dots the age of coming out of people of the LGBTIQ community. And what we see is that over the time, here's 2011, 12, 13, 14, 15, 16, 17, up to 2017, when this study was conducted, from 1970, the social acceptance of the LGBTI community has risen significantly, has risen very, very strongly over the time. At the same time, the age of coming out, we look here at the left, the age of coming out being in 1979 around 21, 22, has come down to 13, 14, which, as we discussed previously and we discovered previously in the slide of my colleague, leads to more a more visual perception of the gender identity that people actually feel, and giving the possibility to address that and help them find themselves with the identity that they fear, that they did not assign at birth, but that they fear, and be there and support them in this process. So these are actually some very hopeful. This is a very hopeful slide that I brought with me, because even still there's a lot of work to do. It seems that we're working towards the right direction. What we need to do now is broaden it. We need to establish a general social acceptance and develop a mental health and clinical setting where we are not only approachable, but actually approach these groups and help them with their struggles. Okay, so far so good. Now we're going to look at factors that my colleague already mentioned briefly that are a source of help, or that is a protective factor, as we say. And there are several of them. One is identity, resilience, and outness. These are of sorts similar. It means that you have found your properly defined identity, what you think of yourself. I am this, I am that, I am lesbian, I'm gay, I'm a trans woman, I'm a trans man. And you even managed to come out to your surrounding. You know who you are, you found yourself, and you managed to communicate that with your surrounding. These two are protective factors, as we can imagine, because they foster the feeling of being oneself and being accepted, or asking for the acceptance of the surrounding. Being out means I talk about my sexuality, I talk about my identity, and I can discuss, or in best case, I can find acceptance for who I am. And that leads us to the response of our surrounding after we've come out, the social support. And it was shown that increased social support elevated or alleviated, it reduced the number of mental health conditions in the populations that were studied. And it was furthermore associated with heightened or elevated self-esteem and coping ability. So how to cope with stress, for instance, was better in patients of the LGBTIQ community that face social support instead of social stigma and exclusion. Other factors were being in a relationship, having someone they can talk to, decreasing the level of loneliness. Scholarly factors, like having a gay, straight, or gender sexuality alliance at your school, having a mental health counselor at school that you can maybe before addressing your peer groups talk to and develop strategies of how to communicate, how to deal with stress. And exactly. And here, the training of teachers was turned out to be a very important factor in this work as well, where making teachers and professors at university and supervisors sensible to this matter decreased the level of isolation, of stress, and readiness to talk about sexuality, talk about gender identity in these groups, and led to a decreased level of mental health disorders. And lastly, now this is something not so much affiliated with our work as clinicians, but as a society in general, political support. Knowing in the political debate that you are an equal part of society, that you have equal rights, that you can get married, that you deserve to receive the treatment that you require. Risk factors that we mentioned before already, that we just need to have in mind when addressing these people. Family factors. Some of the patients that we would face in clinical routine come from families with very traditional values. That applies, as I've understood, to Vietnam. It certainly applies to Germany, where you have parents from very religious backgrounds and at the same time very progressive children, or children of the LGBTIQ community, clashing over traditional family values, of ideas of how a family should look like. leading here to religion, which can at the same time be protective when it's supportive, and detrimental and a risk factor when very excluding of the group of the LGBTIQ community. So far about protective and risk factors. Lastly, we want to look at what we can do. What we can do as clinicians, as mental health experts, but also as a society. And one thing that my colleague already mentioned that Anne also asked for is to have a system that enables the contact to the healthcare system, to have in place something where people of the LGBTIQ community can go to, can present themselves and talk about the issues that they face, which we should not forget is oftentimes something that as a cis heterosexual group we would not face in a daily life. So they have very specific and very detailed problems that needs a good understanding and level of empathy and knowledge about the struggles that they face that one would maybe not face in a daily life. Establishing social support groups, something that has proven in the US where it was performed to be very, very helpful in coping with stress related to the LGBTIQ community and their stigma. Setting or developing a legal framework and political support for these groups, as in acceptance of gender transitioning, as in setting up a legal framework that allows same-sex marriage, as in just acknowledging their needs and their basically existence as a first step is something we can do. Now, here comes the interesting part about clinical practice, what we as clinicians can do. First, we as a psychiatrist, we understand that we have a special role in the treatment of mental health conditions, also in the LGBTIQ community, and therefore have developed special therapy sessions designed for people with problems of the LGBTIQ community. But besides the clinical interventions, we shall not forget that we need to at first help these people identify or find their personal identity when it comes to gender, when it comes to sexual preferences. We shall not forget couples and families of these individuals and their stigma that they express towards the individuals, and therefore also should not forget to include parents, sisters, cousins, uncles in the therapy of these patients. Now, something besides the psychiatric care of it is the gender affirming therapy, a topic that we have heard before and that we have also learned about in talks during the last couple of days, and that is scientifically and politically still at times in discussion. And part of the discussion that was also questioned before was, well, what about the regret that people would face after undergoing gender affirming therapy? And as we've seen before, gender affirming therapy is reducing mental health conditions, mental health problems. And on the other side, the question is, how much risk is there associated with gender affirming therapy when it comes to regret of the feeling of wanting to transition back, of having done unrepairable mistake by affirming the gender? And what we see and find there is that this level of regret is very, very low. The highest estimate we found in the search for studies on this topic was that at most 1% of people face some sort of regret after gender affirming therapy. And only 35 and we rounded up to 40% of this 1%, so 0.4% at the end, had a regret associated to the gender transitioning itself. So a very, very low number. Whereas on the other side, there's a lot of benefit coming from the gender affirming therapy. The other forms of regret were related to social regret of the way they were perceived in their family, in their friends group, at school, at university, at work. And this again comes back to the topic of stigma that we will need to address jointly as andrologists performing the transition and psychiatrists accompanying the patients during this process. And medical regret in the sense of surgery that went wrong or medical side effects, something that happens in most, if not all, therapies, that something can go wrong in the sense of a side effect. I'm going to skip this. This is just a list of the individual responses. And then once again, look at the effect that gender affirming therapy has in a positive sense. And this has my colleague already presented very well. It is short and brief, associated with an elevation or with an improvement of mental health among a spectrum of conditions. It is associated with a lower risk of suicidal ideations or even suicide attempts. It is associated with a reduction of stress, anxiety, and depression. And at the end, it is associated with a reduction in mental health, but in general, medical treatment utilization. So people needing less counseling afterwards, needing less therapy afterwards, and feeling overall at the end happier with who they are and who they have always been. And with that, I want to conclude with the presentation about the LGBTIQ community, about mental health conditions specific in this group, and what we can do to help them alleviate, to help them facilitate finding themselves in this process. And yeah, I have a very similar slide of our clinic, and would be happy to meet you one time there, but for now I'm happy to engage in the Q&A if there are any questions.